Welcome to today's NCLEX RN review session, and in this session we will cover pre-procedure nursing responsibilities, including patient preparation, necessary assessments, and important pre-test instructions. Also, post-procedure nursing care, focusing on monitoring for complications, patient education, and recovery considerations. We also include key diagnostic findings and their clinical significance to enhance your understanding of test results, including potential risks and nursing interventions to prevent and manage complications such as bleeding, infection, or adverse reactions. And our goal here is to sharpen your critical thinking and clinical judgment so you will feel confident answering NCLEX RN questions. Let's get started with the Q&A. Question number 1. The nurse is preparing for a client for an endoscopic retrograde cholangiopancreatography ERCP with intervention scheduled for the next morning. Which nursing interventions should the nurse implement in preparation? Select all that apply. Options: A. Keep the client NPO for 8 hours. B. Check for iodine or shellfish allergies. C. Verify with the client the date and time of the last dose of clopidogrel. D. Administer prophylactic antibiotics. E. Inform the client about receiving conscious sedation. F. Reinforce teaching about risks like pancreatitis and perforation. G. Ensure a recent barium study is cleared by X-ray. H. Ensure full bowel prep with polyethylene glycol. The answers are the following. We have A, B, C, E, F, G. Of course, letter A is one of those. You got to keep the patient NPO, which will prevent the aspiration during sedation, and it will also ensure the stomach is empty for the procedure, which involves endoscopic insertion. And this is a standard requirement for ERCP. And the question mentions scheduled for the next morning. So the NPO status should be established the night before. Letter B is also correct because ERCP uses contrast dye that contains iodine, which can cause allergic reactions in patients with iodine or shellfish allergies. And it's very critical for you to assess for these allergies to avoid adverse reactions or anaphylaxis to the contrast during the procedure. And letter C is also correct. It's because clopidogrel is an antiplatelet medication, and this should be held 5 to 7 days before an invasive procedure like ERCP to reduce bleeding risks. And so your role here as the nurse, you need to confirm when the patient last took it to decide whether the procedure should be canceled or maybe rescheduled. And the clue here in the question, it said it refers to medication safety, right, before the procedure. So it really highlights the importance of confirming when the clopidogrel was last taken. Letter E is also one of the correct answers because ERCP involves moderate sedation or conscious sedation where the patient remains drowsy but responsive. And this is very critical for you to inform the patient about this sedation type so they will understand the procedure and feel less anxious. Now, letter F is also correct because the ERCP carries many risks such as pancreatitis and perforation. Even though the provider or the gastroenterologist is responsible for explaining these risks, but it's also your role to reinforce the information to ensure the patient understands the potential complications. Now, what about letter G? This is also one of the correct options here. Well, if the patient had a recent barium study, the barium may interfere with the visualization of the bile ducts during the ERCP. And an X-ray will confirm that the barium has cleared, which is very necessary for optimal visualization during the ERCP. Now, why not letter D, which is the administration of prophylactic antibiotics? Well, these are given only to patients with specific risk factors, such as biliary obstruction or infection risk. And These are not routinely given for all ERCP procedures. Why not letter H? Well, the ERCP focuses on the bile and pancreatic ducts, not the lower gastrointestinal tract. And so full bowel preparation with polyethylene glycol or Go Lightly is unnecessary for this procedure. Now, let's talk about the preparation for this procedure. What is this ERCP? Well, I want to emphasize here that the ERCP that we are talking about here, it said something about intervention. So it is specifically mentioned in the question. Now, what does it mean when it says ERCP with intervention? Well, this is basically a term that is going to allow the gastroenterologist to examine the ducts, but they'll also perform a treatment if needed. Now, why is it done? Well, the reason for that is it's going to remove the gallstones that are probably stuck in the bile or pancreatic duct. And also this is intended to place a stent and to keep a narrow duct open. And it is also intended to widen the duct, especially the biliary duct, using that balloon to dilate that passageway. And it's also intended to do a biopsy if a tumor or any abnormal growth is found. Now, it is also used for this procedure, sphincterotomy, wherein there is going to be cutting of a tight muscle, and this is intended to improve the bile or the pancreatic juice flowing. And so there are many things that you need to do before the ERCP is done. Make sure that you have verified the consent has been done or signed by the patient or maybe the medical proxy. Make sure that the patient has been NPO for this duration, about 6 to 8 hours before, and make sure that you check for their allergies, especially to the contrast dye or iodine. And you need to also review their chart for any bleeding risks. So make sure that you thoroughly review their medical history, or if they are taking any anticoagulants or antiplatelets or warfarin maybe. And make sure that you also have to establish that patent IV access. Now, what are you going to do after the procedure? Well, you need to monitor the patient for any signs of bleeding. That is number one. So they might have some hematemesis or maybe black stools, and this is something that we really need to track for. Another thing is the infection, such as fever. There might be some chills or any development of jaundice that could indicate a blockage. Maybe a stone might have blocked into the biliary tree. So that's something that you gotta monitor as well. Now, another thing is to monitor for pancreatitis. So maybe the patient will end up with abdominal pain, nausea, and vomiting. So this is a very common complication for this procedure. Another thing that you need to pay attention is the perforation. So the patient will complain about severe abdominal pain. There's going to be fever, rapid heart rate, and this suggests that there is ductal injury. Now, if this is done as an outpatient, well, you got to make sure that the patient has someone to drive them home, especially that this involves some sort of sedation. All right, let's have number 2. Now, a 62-year-old client has just returned to the nursing unit after an esophagogastroduodenoscopy EGD. Which action by unlicensed assistive personnel requires the nurse to step in? Options: A, gently cleaning the client's mouth with a damp cloth. B, offering the client water from a pitcher. C, monitoring vital signs every 30 minutes. D, positioning the client on their right side. The answer is letter B. And why is that? Well, after an EGD, the patient may still have a diminished gag reflex, which means they are at risk for aspiration. Now, if the gag reflex is not fully returned offering water could lead to choking or aspiration pneumonia, which are serious complications post-procedure. And the RN needs to assess the gag reflex before a patient is given anything to drink or eat. Now, the clue in the question is that the patient just returned from the procedure, means that there is a high likelihood that the gag reflex is still impaired. And so your role here as the RN, you need to make sure that it's safe for the patient to take anything by mouth. What about letters A, C, and D? Why is letter A not the answer? Well, of course, this is a safe, appropriate task for the unlicensed assistive personnel. And this is going to help the patient feel more comfortable after the procedure. And it doesn't really pose a risk to the patient. So eliminate this one. Same thing with letter C. Monitoring vital signs every 30 minutes is also an essential intervention, especially right after this kind of procedure, to check for any complications such as bleeding or any changes in the blood pressure. And positioning the client on their right side. This is also an intervention that is commonly done after procedures to reduce the risk of aspiration or to help any remaining sedation. And there's no issue with this task in D as well. Let's have number 3. A client has just returned to the recovery area following an upper endoscopy. Which information should the nurse prioritize communicating to the healthcare provider? Options. A, the client's temperature is 101.5 degrees Fahrenheit. B, the client appears extremely drowsy. C, the client mentions having a sore throat. D, the client's heart rate is 100 beats per minute. The answer is letter A. This is a fever. And this could suggest a serious complications like perforation, which may occur during or after the endoscopy. And take note that a perforation is something that can complicate to peritonitis, sepsis. So it's very important to notify the healthcare provider immediately to assess and manage the situation. And what about letter B, C, and D? Let's start with letter B. Well, the patient appears extremely drowsy. This is typical after the use of sedatives during the procedure. So it is important for you to monitor the patient's level of alertness, but it doesn't indicate an acute problem that needs immediate attention from the healthcare provider unless it worsens. What about letter C? The client mentions having a sore throat, and this is a common symptom after an endoscopy due to the insertion of the endoscope through the mouth and throat, and this usually will resolve on its own without medical intervention. Letter D is also incorrect because the heart rate of 100 beats per minute is within the normal range, especially immediately following a procedure involving sedation. And the tachycardia, the slight tachycardia, can occur as part of the body's response to the procedure, but it's not necessarily a cause for concern unless it's accompanied by other signs of distress. Now, I want you to look for signs of critical complications like infection or perforation, and you need to prioritize those when answering this type of questions. And I need you to eliminate those expected post-procedure symptoms like drowsiness, sore throat, or mild tachycardia, which are common and typically not urgent. And you also need to assess the severity of the symptoms, and the fever mentioned here is more likely to point to a serious issue than other more expected signs following this endoscopic procedure. 4. A 4 to 6-year-old client is scheduled for a gallbladder ultrasound in the outpatient testing area. Which of the following findings would suggest that the ultrasound should be postponed? Options. A, the client had a fatty meal the night before. B, the night ate a slice of cornbread 4 hours ago for breakfast. C, the client has a permanent gastrostomy tube in place. D, the client took a laxative last night. The answer is letter B. And why is that? It's because eating even a small meal can trigger gallbladder contraction, and it can potentially interfere with the accuracy of the ultrasound results. Now, For the best imaging, the patient should be NPO for at least 8 to about 12 hours before the procedure to ensure the gallbladder is in a relaxed state. Now, the key phrase here is eating, right? And so this directly impacts the test results. And also the question specifies that the client ate a slice of cornbread just hours before the procedure. So it is really a primary factor for rescheduling. Now, what about letter A? The client had a fatty meal the night before. Well, even though it's true that the fatty meals can affect the gallbladder, causing it to contract, but the effect of the meal is usually temporary, and a high-fat meal from the previous evening is unlikely to disrupt the test results. And letter C, the client has a permanent gastrostomy tube in place. Well, having a gastrostomy tube does not interfere with the ability to perform a gallbladder ultrasound, and this condition would not require the ultrasound to be rescheduled unless there were other complicating factors such as infection or maybe drainage. And the presence of gastrostomy tube alone is not an issue for the ultrasound, so you can eliminate this as well. Now, why not letter D? The client took a laxative last night. Well, it does not affect the gallbladder's ability to be visualized via ultrasound, and it's not an obstacle to performing the test unless it leads to dehydration or other complications, which are not indicated in this case. So I want you to focus on how the food intake affects the procedure, especially within the time frame that they're supposed to be NPO. And I want you to eliminate those options that don't directly impact the ultrasound's effectiveness, such as laxative use or the presence of gastrostomy tube. And you also need to consider the timing and impact of meals, such as a low-fat meal eaten shortly before the test, or let's say the cornbread rather. It's more likely to interfere with the results compared to a meal that was consumed the night before. Let's have number 5. Following a needle biopsy of the liver at the client's bedside, what should the nurse do next? Options: A, raise the head of the bed. B, place the client on the right side with the bed in a flat position. C, put pressure on the biopsy site using a sandbag. D, review the client's coagulation studies after the biopsy. The answer is letter B. It's because after a liver biopsy, positioning the patient on the right side with the bed flat can help apply pressure to the biopsy site, and it will also minimize the risk of bleeding by splinting the area. And this position can also help keep the liver and the surrounding structures immobilized, and it can also reduce the likelihood of complications. And so, what about letter A, raise the head of the bed? Well, raising the head of the bed is not necessary unless there's respiratory concerns. And the main priority post-biopsy is preventing bleeding by positioning the patient onto their right side. And letter C, put pressure on the biopsy site using a sandbag. Well, it does not really provide sufficient pressure to control the bleeding at the biopsy site. The correct action here is to position the client onto their right side to apply pressure naturally and also to prevent complication. All right. What about letter D? Review the client's coagulation studies after the biopsy. The word that makes this statement incorrect, it's after. Well, supposedly the coagulation study should be reviewed before the biopsy to assess the patient's bleeding risks. After the procedure, the nurse's priority is to position the client to prevent the bleeding, not reviewing the lab results. And our immediate task here is to make sure that there is constant pressure to the puncture site for about 1 to 2 hours. Now, let's talk about the liver biopsy in much more detail this time. And so the Liver biopsy involves the removal of a very small sample of the liver tissue to examine it under a microscope. And this is typically used when the liver disorders can't be diagnosed with other tests, such as maybe unexplained liver enlargement or maybe persistently high liver enzymes, the AST, ALT, are so high, and maybe there is suspicion of tumors. There is a primary or metastatic type of cancer suspected. It could be maybe unexplained jaundice, or maybe suspected hepatitis, and maybe sarcoidosis or amyloidosis, and some disorders such as hemochromatosis or Wilson's disease. And this is also done for those cases where biopsy is very necessary to determine the severity of the disease. Now, I want to emphasize here that there are types of biopsy pertaining to the liver biopsy. One is the guided liver biopsy, and this is done when a specific area of the liver is targeted, let's say a tumor. And imaging like a CAT CT scan or MRI or maybe ultrasound will also be used to guide the biopsy needle to correct the location, or let's say the puncture. The other one is the blind liver biopsy, and this is used when the liver is diffusely affected and the needle is inserted without the help of any imaging guidance. Now, the liver biopsy itself has contraindications, and there are some cases wherein clients may not be suitable for a liver biopsy, maybe because they cannot stay still or hold their breath during the procedure, or maybe they have bleeding disorders, or they have anemia, and they could probably have some struggle with the blood loss, and maybe some infections near the biopsy site, maybe in the right pleural space or right upper quadrant. Or maybe they have obstructive jaundice where bile may leak after the needle insertion. Or maybe for those patients that may have a vascular tumor or a hemangioma due to increased bleeding risk. And for those clients that may have ascites, and it will also increase the risk of fluid leakage. Now, take note that the liver biopsy also can lead to potential complications, and these can be rare but very dangerous when this happens. And so we have hemorrhage caused by the accidental puncture of a blood vessel in the liver, possibly a chemical peritonitis wherein the biopsy needle accidentally punctures the bile duct and the bile leaks into the abdominal cavity. And we also have the pneumothorax wherein it can lead to a collapsed lung, and this can occur when the needle improperly is inserted and punctures the lung. Now, take note that before the procedure is done, we need to make sure that we have cleared our patient, make sure that we have done our best to educate the client, which is very crucial. Make sure that we explain to the patient and also address any concerns that they might have, or if they did not really understand the procedure, then we need to make sure that the patient talks to the medical provider or vice versa. Now, we also need to check for the coagulation studies, making sure that the patient's blood clotting is normal, and this will help prevent bleeding during the procedure. And make sure that you verify that the informed consent has been signed before they receive any sedative, and make sure that they are kept NPO after midnight before the biopsy to reduce the risk of infections. And also, we are going to establish the IV access so the nurse in the pre-op or the pre-procedure area can administer those sedative medications to help the patient relax. Now, after the procedure, you're going to make sure that the small dressing that is sterile is applied directly over the insertion site, and you're going to assist the patient to position to their right side for 1 to 2 hours to reduce the risk of bleeding and bile leaks. You also have to monitor the vital signs frequently to check for signs of hemorrhage, such as tachycardia, low blood pressure, and fever, which could signal that there is peritonitis, perforation possibly. And if laparoscopy was used, routine post-operative care will be needed here as well. Now, aside from these, we're also going to have to assess the client for their respiratory function, check for any chest pain, difficulty of breathing, as we know that pneumothorax can happen as well if there is accidental puncture to the lung tissue, and also make sure that you're assessing their changes in the breathing that could suggest that there is pneumothorax, like another complication. Now, what are the key priorities that should be taught to our patient, especially before they get to this procedure? Well, we want to make sure that they understand to report any signs of bleeding, especially that they probably would feel palpitations or increased pulse rate, or if they're feeling any fever, or if they feel just warm, this could be a sign that there is developing peritonitis. And also advise the client to avoid coughing, straining, or any activities that could increase the intra-abdominal pressure. And also, you have to teach the patient to avoid any strenuous activities and heavy lifting for about 1 to 2 weeks after the procedure to prevent increased intra-abdominal pressure, which could lead to hemorrhage, bile leak, and hematoma formation. Number 6, the nurse is preparing a 56-year-old female client for a scheduled colonoscopy. Which of the following details should be reported right away to the healthcare provider before the procedure? Options. A, the client refused to drink the prescribed polyethylene glycol golightly. B, the client has had allergic reactions to both shellfish and iodine in the past. C, the client is so anxious about potential discomfort during the exam. D, the client has a permanent pacemaker to prevent bradycardia. The answer is letter A, because for a colonoscopy to be effective, there should be proper bowel preparation, such as completing the required amount of the polyethylene glycol or the golightly. And the client is supposed to finish the entire amount. This is actually more than 1 to 2 liters. And this is to make sure that the client's bowel is cleansed to ensure clear visualization during the procedure. So make sure that there's no longer fecal material that can be seen before the procedure. And if the patient has not adequately prepared the colonoscopy, this may need to be rescheduled. Now, the question here focused about preparation for the colonoscopy, and so making the refusal to complete the bowel prep the most critical piece of information to report to the healthcare provider. Now, what about letters B, C, and D? Let's start with letter B. This is incorrect. We know that iodine allergy is relevant in other procedures involving contrast media for the CT scans or maybe certain imaging procedures, but colonoscopy does not require contrast. And so this is not going to be a critical aspect of this procedure. Now, what about letter C? The client is anxious about potential discomfort during the exam. Although patient anxiety about a potential discomfort is significant, but it doesn't necessitate communication with the healthcare provider regarding their readiness for the procedure. And what we can do here as nurses is that we can manage their anxiety effectively by providing patient education and reassurance. And the anxiety is not a procedural barrier. It's an emotional concern that can be managed by us during the pre-procedure teaching. Now, letter D. This is also incorrect. The pacemaker does not affect a colonoscopy. And managing a pacemaker is important for other procedures like MRI, but not for colonoscopy. Now, I want you to review some essential RN tasks before the procedure. And so I want to make sure that you are aware our role here. And so before the patient goes for a colonoscopy, make sure that they understand the purpose of the procedure and what to expect. It's not really our primary role, but we can reinforce what the medical provider has explained to the patient. And we also need to ensure that the patient has signed the consent, and also they need to follow a clear liquid diet about 1 to 3 days before the procedure. We also need to review their medical history to see if there are any comorbidities that might contraindicate. And also, we have to prepare the client for sedation. Now, we also need to assist the patient during their bowel preparation. This can include the use of the Go Lightly. That's large volume liquid that they need to keep ingesting after a clear liquid diet 24 hours prior. So they're going to do this overnight to make sure that their bowels are cleaned up. Now, we also need to monitor the vital signs to see if there's any complications, especially that this can lead to watery stools. And some of these patients, especially the elderly, are really prone to electrolyte fluid imbalances. So this is something that you need to pay attention as well. Now, make sure that our patient is also NPO. This is very important, at least 6 to 8 hours before. And another thing that we need to do, post-procedure task, make sure that you're monitoring the client for the sedative effects of the medication right after when they come back from the procedure. Make sure that they're going to be monitored for the possible adverse effects of the procedure. There are so many things that can potentially happen. They could probably have some perforation. The client will complain of severe abdominal pain, and this can really complicate into peritonitis and sepsis as well in just a matter of few hours. So this is something that you need to keep an eye out. Now, you also need to warn the client for any bloody stools or maybe black stools, because this might indicate bleeding, and this is something that should be reported right away. Now, also pay attention to the succeeding diet and fluid intake, and this is something that they can do once they're fully awake, and they can gradually resume eating, starting with the clear liquids after the procedure, and then progress to a light diet as prescribed by the gastroenterologist. Now, we're also going to have to encourage the client to increase their fluid intake orally to rehydrate and also replace their fluids lost during the bowel preparation. And another thing is to monitor for their bowel movement, and also for any manifestations. They might experience some mild bloating or gas for a short time after the procedure, and this is due to the air, the insufflation that is used during the colonoscopy. And also assure the patient that regular bowel movements should return within a few days. Now, also the task that you need to implement here is to ensure that they adhere to the follow-up care, that they need to show up for their appointment with a healthcare provider for the results of the testing or the biopsy maybe. And they need to also monitor their manifestations at home. If there's any complications, such as severe abdominal pain, any signs of bleeding in their GI tract should be immediately reported to the gastroenterologist. And also, you have to encourage the client to rest for the rest of the day and avoid any strenuous activities. Alrighty, let's have number 7. Which clinical finding should the nurse assess before scheduling a client for an endoscopic retrograde cholangiopancreatography or ERCP? Options: blood pressure, B, serum glucose, C, urine output, D, bilirubin level. The answer is letter D. So before performing the ERCP, it is very important for us nurses to assess the client's bilirubin levels. And if there is any value greater than 3 to 5 milligrams per deciliter, this may indicate severe obstruction. And usually the procedure will be postponed in such cases. Now, performing the ERCP in a patient with high bilirubin levels can exacerbate the bile duct obstruction due to the potential swelling and also edema from the cannulation. done by the gastroenterologist, and this will make the obstruction worse. Now, the clue in the question is that the ERCP procedure involves the insertion of a cannula into the bile ducts. And so if there is elevated bilirubin levels already, this would be an important consideration for the healthcare provider to ensure safe management of possible complications. Now, what about letter A, blood pressure? We know that blood pressure monitoring is an important part of the overall clinical assessment, but it is not a direct contraindication or consideration for performing ERCP. And the blood pressure levels do not influence the ability to safely conduct the procedure. Now, what about letter B, serum glucose? This is also incorrect. We know that this is critical for managing diabetic patients undergoing ERCP, or let's say for those clients that need assessment of their metabolic issues, but this do not directly affect the decision to schedule an ERCP. And letter C, urine output, is also a critical parameter for kidney function and hydration status, but it is not directly going to influence the decision to schedule the ERCP. We know that the monitoring of the urine output is important for general care, but it does not specifically impact the safety for this patient before the ERCP. Let's have number 8. A client experiencing blood in their urine is scheduled to undergo cystoscopy with cystogram. Which of the following explanations from the nurse best describes what will happen during the procedure? Options: A, the doctor will insert a tube into your bladder and pass small tubes through it into your kidneys. B, the doctor will insert a tube into your bladder via your urethra, examine the bladder, and inject dye for imaging purposes. C, the doctor will inject a radioactive substance into a vein, and this will allow your kidneys and bladder to be seen on imaging. And D, a catheter will be placed into an artery near your groin, and dye will be injected to view the blood flow to your kidneys. The answer is letter B. Well, because the cystoscopy with cystogram involves the insertion of a thin, it's a lighted tube that is going to inspect the insides of the bladder. And when it is inserted into the bladder through the urethra, this is going to allow visualization of the tissue, the lining of the bladder. And a contrast dye is then injected into the bladder to create a clear X-ray image. And the goal here is to evaluate any potential problems within the bladder, maybe tumors or maybe stones or abnormal growths. And that's why we have that as our option. Now, what about letter A? This statement in letter A describes another procedure, which is retrograde pyelogram, which is a procedure used to visualize the kidneys by inserting catheters into the bladder and ureters. And the focus of this procedure is on the kidneys, right? Not the bladder, which is what is being described in the question. And we have letter C. This is also incorrect because this statement refers to a nuclear scan or radionuclide cystography, which uses a radioactive tracer that is injected into the bloodstream and to monitor the distribution of the substance in the body. And this is not what happens in a cystography or cystoscopy with cystogram, which is using a contrast dye or for the imaging. Now, what about letter D? This is also incorrect, right? This is a statement that describes renal arteriogram, which is another procedure to evaluate the blood flow to the kidneys by injecting contrast dye into the arteries. And this is so unrelated to the procedure that we are talking about in this case. All right, let's have number 9. But before we're going to do that, let's do a quick review of what cystography or cystoscopy with cystogram is, and the procedure itself. So I'm just showing you a quick picture here of what it's supposed to look like. So the tube is pretty much a flexible material that is inserted into the urethra, and it has a camera that will allow visualization into the internal structures. And so it has diagnostic uses. One is to inspect and also to do biopsy in the following structures such as the prostate, the bladder, and the urethra. For example, if there are any conditions like cancer or maybe infection, so this is going to be a very helpful type of diagnostic testing. And also it can enable collection of urine sample from each ureter for accurate testing, and this is often going to be using ureteral catheters as well. Another is that it can measure the bladder capacity, also to assess the bladder function. It will also check for urine reflux from the bladder into the ureters, which can lead to the kidney damage. And it can also identify stones in the bladder, or any blockages or any discomfort. So that's why we have detection of calculi. Now, it could also identify the source of hematuria and to locate the cause of the blood in the urine, which may originate from the bladder itself or maybe from the ureters or the kidneys. Now, take note that the cystoscopy and cystogram can also have therapeutic uses. It will also help in resecting those small bladder tumors, which can be removed through the urethra, and it will kind of avoid major surgery procedure. And also, it is also going to remove any calculi. They're going to extract the small stones through the cystoscopy as well, or maybe any foreign body. And this is also done to dilate the urethra. If there's any narrowing or stenosis in the urethra, this can be treated by widening them, improving the urine flow. And stent placement is another reason. This is going to be done to drain urine from the kidneys, especially when there's blockage or other issues. And it can also help stop the bleeding within the bladder, or let's say any bleeding that is originating from the ureter. So the medical provider here can actually do the cauterization to stop the hemorrhage. Now, we also have other complications that can happen with this procedure, and one of those is the bladder or ureteral perforation. Because this is a invasive procedure, it can possibly cause accidental tearing of the bladder or the ureters during the procedure. Possibly the patient will develop sepsis, especially if there is ascending spread of the infection in the bloodstream leading to this life-threatening condition. It can also lead to hematuria, a very common post-procedure, but it's something that you should be monitoring as well. Now we have urinary retention, which can happen due to a possible swelling or injury on the urethra during the procedure. So you got to monitor for the urinary output as well. And after the procedure, or actually before the procedure, the client needs to obtain that appropriate information. We want to make sure that the client has thoroughly understood the procedure and make sure that we verify that the consent has been signed. And if there's any doubt or the patient did not really understand the procedure, then we need to notify the medical provider so that they can re-explain to the client. Now, we also need to educate the client about the anesthesia that is supposed to be used. And so local anesthesia can also cause some possible discomfort, which is greater than with catheterization. And if in case the client will require general anesthesia, the patient will be placed NPO after midnight. We're going to have to provide fluids via IV if the client is admitted in the hospital already, and also to follow standard anesthesia protocols. Now, we also have to establish IV access before the procedure is done and make sure that we administer those pre-procedure medications. Number 9. After performing a cystoscopy, the nurse should ensure that the client, options A, is advised to remain in bed for 4 to 6 hours to rest. B, understands that blood-streaked urine is a common expectation. C, learns to ask for pain medication if needed, such as narcotics. D, is instructed to stay NPO for 8 hours to avoid vomiting. The answer is letter B. And why is that? Because after a cystoscopy, it is entirely expected for the client to experience blood-tinged urine, and this is happening due to the irritation of the urinary tract during the procedure. And in addition to that, the patient may also have increased urinary frequency and maybe some burning sensation while urinating. And these are common temporary symptoms that can resolve within a short time. And it is important for us nurses to inform that the patient is aware about these so they are not too alarmed, right? Now, what about letter A? Advised to remain in bed for 4 to 6 hours to rest. This is incorrect. We know that bed rest is generally not required after a cystoscopy, and even though patients should rest for the first few hours, they are usually encouraged to resume normal activities soon after the procedure, and the prolonged bed rest is so unnecessary unless complications can happen, which is not typical for this procedure. Now, what about letter C? This is also incorrect. We know that some discomfort, like a burning sensation during the urination, is common after cystoscopy. But the pain severe enough to require narcotics is not expected. And the moderate pain that they're going to be complaining about will often be relieved by common pain relievers that are typically sufficient for managing any minor discomfort. And the narcotics are not typically required after this procedure. And the emphasis should be on the mild discomfort rather than the severe pain. And the focus is on managing minor symptoms with appropriate interventions. Now, what about letter D here? Is instructed to stay NPO for 8 hours to avoid vomiting. Well, there is no need for the client to remain NPO after a cystoscopy unless they are undergoing another procedure like anesthesia that requires fasting. And the primary concern after a cystoscopy is managing any minor urinary symptoms, not preventing vomiting. And so the NPO status is commonly required before the cystoscopy or when there is a requirement for general anesthesia, but cystoscopy is usually a local anesthesia procedure and fasting is generally not necessary. Let's have number 10. But before we're going to go to that, let's have a quick review about the post-procedure care after a cystoscopy. And so what you're going to do here is to instruct the client not to walk or stand alone to avoid dizziness. And this is because the client, the client is actually going to be placed in that procedure room table, right? And they're going to place the client's thighs on those stirrups. The legs rather. And so the position alone can cause orthostasis or orthostatic hypotension because of the prolonged time when the client has been placed with that position. And so you got to make sure that the client is assisted when they are repositioned from their position in that table, and then when they are transitioning into a sitting or standing position rather. Now, another thing that you need to do is to monitor the client's voiding for 24 hours. This is very important that they also know, or they should expect that they should be able to put out urine adequately within that time frame. Okay. If the client cannot void, let's say, about 4 to 6 hours after the procedure, even though they have some volume in their bladder, then that's really concerning. Maybe there is already an issue with urinary retention, and this is something that needs to be reported right away, because we don't want urinary retention. This can lead to some infections as well. Now, we also need to instruct the patient to report any bright red blood or clots, while if they're only reporting pink colored urine, that is normal, so they should not be alarmed about that. But our emphasis here is to make sure that the client reports bright red urinary output. This simply means that there could be some bleeders that needs to be cauterized. Now, there's also a need for us to educate the client about making sure that they are aware that the burning sensation when urinating is something that is expected. And what we can do to help this patient is to allow the male client to sit while they are urinating to avoid vagal reactions. And this is a temporary intervention. Now, another thing is to encourage fluids, especially oral fluids. And this will help dilute the urine and also to prevent infection, allow washing of their urinary tract. We also have to watch the client for any signs of sepsis, such as fever, low blood pressure, high tachycardia maybe. And also to remind the patient that if they have a pre-existing prescription to complete the antibiotics, maybe they have a pre-existing order to do it or to take the antibiotic before the procedure, and also to keep taking the medication after the cystoscopy, then make sure that they adhere to that prescription. Now, we also have to encourage cathartics. This is very important to prevent constipation. And we really don't want our patient to bear down and do the Valsalva's maneuver, because this can also lead to some bleeding, urinary bleeding after the procedure. So make sure that they are using those two softeners as well. And if there is such a case that the client may have a urinary catheter that has maybe a three-way catheter that is intended to do maybe irrigation, and so we're going to have to instruct the client, if they're able to do it when this is done as an outpatient type of procedure, then they can also use the isotonic solutions to prevent fluid overload. And also make sure that they understand the catheter care to make sure that it remains in place for the duration. Now, very important here is to make sure that the client understands their care at home. So we need to teach them about monitoring their urinary retention for the duration of 24 to 48 hours. This is very critical. We need to make sure that they understand to watch for any signs of bleeding. Again, appearance of clots is abnormal. This should be reported right away. If they see that they have pink urine color, that is expected. They should not be worried about it. If there's any reports of abdominal pain, lower abdominal pain, if it's increasing, this is something that they need to communicate right away to the healthcare provider. And also to encourage the use of sitz baths, and also the use of the B&O. This is the belladonna and opium, and this is a prescription medication suppository that can help reduce the bladder spasms, and also to encourage oral fluids that will help flush out the system and to reduce the discomfort, and to monitor the client for any signs of urinary tract infection. So you can teach the client to observe themselves for any of these manifestations, and to also emphasize completing the remainder of the prescribed antibiotics to ensure that they have completed the entire course to prevent reinfections. Now let's talk about number 10. A client with a suspected duodenal ulcer has just undergone an esophagogastroduodenoscopy EGD. As part of the client's care plan, which action should the nurse prioritize? Options: A, observing the return of the gag reflex. B, monitoring for sore throat and offering warm gargles. C, observing for complaints of heartburn. D, checking the client's temperature regularly. The answer is letter A. This is the highest priority after an EGD to ensure the patient's airway is intact and safe. And we know that the gag reflex is a critical protective mechanism to prevent aspiration. And so, until the gag reflex returns, the client is at higher risk of aspiration if they attempt to swallow anything, including their saliva. And so, it's very important that we are monitoring this. And so, what about letter B? Why is letter B incorrect? Because this is a common or an expected effect after the procedure. And this is caused by the passage of the endoscope through the throat. So this does not pose an immediate risk to the client's safety. And this is something that can be managed with soothing measures like warm gargles, but it should not be prioritized over assessing the gag reflex, which is directly related to airway safety. Now, what about letter C, observing for complaints of heartburn? Well, the heartburn or discomfort can occur after an EGD, particularly if there is irritation from the procedure or underlying reflux. And this one doesn't really take precedence over the need to ensure the patient's airway is protected by assessing the return of the gag reflex. And option C is something that you can address later once the patient's safety is secured. Now, what about letter D, checking the client's temperature regularly? This is also an important part of the post-procedure care to detect any potential complications such as infection or GI perforation, which could present as a fever. However, the patient's airway is the first priority, and checking the temperature regularly should come next after you had ensured that their gag reflex has returned. So again, I want you to go back into the question stem. You are actually going to prioritize the intervention or prioritize that assessment. So we are going to focus on the most critical and immediate concern, which is airway safety. 11. A nurse has provided education to a client who is scheduled for an endoscopic retrograde cholangiopancreatography ERCP due to suspected gallbladder disease. The nurse identifies that further clarification is needed when the client says, option A, I'm relieved that I won't need to remain still during the procedure. B, I'm glad I'll receive some IV medication to help me relax. C, I understand that I will need to sign the consent form. D, I'm hoping the throat spray will help prevent gagging. Again, your task here is to choose that answer or option that reflects further clarification is needed, and that is letter A. For an ERCP, the client is required to remain still throughout the procedure, which typically lasts about an hour. And this is very critical for both the safety of the procedure and to ensure accurate imaging. Now, if the patient expresses relief about not needing to lie still, this suggests a misunderstanding of the procedure, which the nurse needs to address right away. So, the patient needs to be informed that staying still is very critical for the procedure's success. Now, what about letter B? I'm glad I'll receive some IV medication to help me relax. This is a correct statement coming from the patient because intravenous sedation is given to help relax the patient, and it will make the procedure more comfortable. And the patient in this statement correctly recognizes the role of the sedation in reducing their anxiety and discomfort. Now, what about letter C? This is also a correct statement. because the client needs to sign a consent form before the procedure, so they understand the risk and the benefits. Letter D is also a correct statement, because a local anesthetic spray is typically applied to the throat before the procedure to reduce gagging and also reduce discomfort when the endoscope is inserted. And again, this is a statement that reflects understanding. 12. A 4 to 6-year-old woman with gallstones obstructing the common bile duct presents with right upper abdominal pain, nausea, and vomiting. Her lab results show elevated direct bilirubin, ALP, GGTP, LAP, and prolonged prothrombin time. Which actions should the nurse prioritize? Select all that apply. Options: A, prepare the client for an endoscopic retrograde cholangiopancreatography, ARCP. B, encourage the client to consume a diet high in fats before surgery. C, monitor the client's stool color for any changes. D, administer vitamin K as prescribed. E, instruct the client to refrain from drinking alcohol. F, observe for signs of worsening jaundice. The answers are letters A, C, D, E, and F. And why letter A? Well, the patient requires ERCP, a procedure that is actually crucial for diagnosing and managing common bile duct obstruction. And it will allow for stone removal and also the clearance of the bile duct. So this can offer symptom relief and also can address the underlying issue. Now, why letter C? Well, the color of the stool is also an important indicator of bile flow. And so when there is clay-colored stools, it suggests that the bile is not reaching the intestines, which is a sign of obstructed bile flow. And so monitoring for the changes in stool color is very critical to assess the patient's progress and also to assess the effectiveness of any intervention such as the ERCP. Now, what about letter D? Administer vitamin K as prescribed. Well, the elevated prothrombin time, it said here in our question stem, her lab results show elevated direct bilirubin, and it includes prolonged PT. And so this indicates that the patient has impaired vitamin K absorption, which is a result of the blocked bile duct. And so vitamin K is a necessary drug for synthesizing the clotting factors. So we have clotting factor 2, clotting factor 7, 9, and 10. And administering that medication will help correct the coagulation issues associated with a biliary obstruction. Now, letter E is also correct, instructing the client to refrain from drinking alcohol because alcohol can exacerbate liver damage and also inflame the bile ducts. And so advising the patient to avoid it is very critical for preventing further stress on the liver and the gallbladder. Letter F is also correct. Observe for signs of worsening jaundice. We know that jaundice is a manifestation of bile duct obstruction, and the elevated direct bilirubin levels that we are seeing in the scenario indicates that there is obstruction, right? And so we need to observe the client for worsening symptoms, maybe dark urine or yellowing of the skin. These are very important assessments to identify if the condition is worsening or progressing. Now, we have letter B as one of the incorrect options, encouraging the client to consume a diet high in fats before surgery. And this is something that should be avoided by the client because it can trigger gallbladder contractions. It can worsen symptoms like pain. And so instead of allowing them to consume a high-fat diet, they need to ingest low-fat diet with smaller meals to minimize the strain on the gallbladder and also to reduce pain and also discomfort. And I want you to look into the labs here. So let's do a quick review about the laboratory tests that were mentioned in the scenario. And so one of those is the direct bilirubin. Normally, it's supposed to be at 0.1 to 0.3 milligrams per deciliter. And when it is elevated, this is reflecting that there is obstructive jaundice, where there is a blockage in the bile ducts. It will prevent the bilirubin from getting excreted into the intestines. And so when the bile flow is obstructed, the bilirubin will build up in the bloodstream. This can lead to jaundice and dark coloration of the urine. And we have number 2, alkaline phosphatase, with a normal range of 44 to 147 international units per liter. And this is an enzyme that is found in various GI tissues, including the liver, bones, and bile ducts. And the elevation of the ALP also reflects cholestasis. There's possibly gallstones. And this is a common finding in the client with cholecystitis with some stones in it. Now, this one, 5-nucleotidase, with a normal range of 0 to 11 international units. This is also an enzyme that is a close indicator of cholestasis or bile duct obstruction. And this is also a specific marker for liver and bile duct dysfunction. And so if there is elevation, this also supports obstructive jaundice or any biliary tract obstructions, maybe caused by the gallstones blocking the common bile duct. We also have the gamma-glutamyl transpeptidase, or the GGTP, with a normal range of 9 to 48 international units per liter. And this is another enzyme that is primarily found in the liver and bile ducts. And this is going to be elevated in conditions wherein there is liver disease or any cholestasis or maybe a biliary tract obstruction. Okay. And this is also a test that is used to differentiate liver disease from other causes of ALP elevation. Now we have the leucine aminopeptidase, or LAP, with a range of 6 to 54 units per liter. This is also an enzyme that is released from the liver when there is biliary tract obstruction or cholestasis. And so this is also increased when there is obstruction in the biliary tree or if there is liver dysfunction. So we have the prothrombin time. Normally, it's ranging at 10 to 13 seconds. And this is going to measure the time it takes for a blood to clot. Now, this is going to be prolonged or increased if there is coagulation dysfunction. And this is often caused by an impaired vitamin K absorption, which occurs in the presence of bile duct obstruction. Since there's no longer bile to emulsify or digest those nutrients in the small intestine. And we know that vitamin K is very important in the synthesis of the clotting factors. We have clotting factors 2, 7, 9, and 10. And when the bile cannot flow into the intestines, the absorption of vitamin K is impaired. It can lead to deficiency of clotting factors and a prolongation of the prothrombin time. Now let's have number 13. It states, a client diagnosed with von Willebrand disease is scheduled for a colonoscopy due to changes in bowel habits. What should be done before the procedure? Options. A, the client should not follow the typical bowel prep routine. B, the client should be admitted to the hospital a day prior to the procedure. C, the client needs to receive clotting factor replacements before the procedure. D, the client should be given fresh frozen plasma, FFP, 2 days before the procedure. The answer here is letter C, because in patients with the von Willebrand disease, it is critical to replace those missing clotting factors, the von Willebrand factor, or let's say the clotting factor 8, before any invasive procedure to minimize any bleeding risks. And this preparation ensures the patient's safety during the colonoscopy. Now, why is A incorrect? There is no reason to avoid bowel prep for patients with the von Willebrand's disease unless there are specific concerns. However, they should receive clotting factor support to reduce the bleeding risk during the procedure. Now, what about letter B? Admission is not necessary for a routine screening colonoscopy. And pre-op management should focus on factor replacement, not hospitalization, unless there is an additional complication. Now, what about letter D? The client should be given fresh frozen plasma 2 days before the procedure. Well, FFP is not the preferred treatment for von Willebrand disease in this context because we are going to administer specific clotting factor concentrates or desmopressin, which are more effective in correcting the deficiency in von Willebrand disease. Now, I want you to go back into the question stem. It mentioned von Willebrand disease. It indicates a clotting issue that requires factor replacement. And the procedure that is invasive, the colonoscopy, it suggests the need to prevent bleeding during the process. Number 14. A nurse is caring for a client who is scheduled for a colonoscopy and whose bowel preparation will include polyethylene glycol electrolyte lavage prior to the procedure. The presence of what health problem would contraindicate the use of this form of bowel preparation? Options: A, active inflammatory bowel disease, B, intestinal polyps, C, diverticulitis, D, colon cancer. The answer here is letter A. All right, so let's talk about the polyethylene glycol, which is the PEG. It's an electrolyte lavage that will work as an osmotic laxative. It means that it's going to pull water into the intestines to flush out the stool before the colonoscopy. While generally it's safe, it can also be risky for patients with active inflammatory bowel disease like Crohn's disease or let's say ulcerative colitis in their flare-up season. I'm talking about active inflammatory bowel disease. And why is this going to be contraindicated? Well, when there is active IBD or if there is flare-up, the colon lining is already inflamed, it's fragile, and the large fluid volume that is being taken in, and also if there is increased peristalsis caused by the PEG, this can worsen the irritation, it can increase the discomfort, and it can also increase their risk of perforation. There's going to be tearing in their bowel wall. And so for patients with IBD, inflammatory bowel disease, gentler bowel preparation options are often preferred. Or the colonoscopy will be postponed if the inflammation is so severe. Okay? So the bottom line here is that the active inflammatory bowel disease is a major contraindication. And so this is our correct option. Now, what about letter B, intestinal polyps? Well, polyps are small growths in the colon, and some of which can turn cancerous over time. And patients with polyps routinely undergo colonoscopy for screening or let's say removal. And the polyethylene glycol electrolyte is a standard bowel preparation for them. And since the polyethylene glycol it's not going to affect the polyps or it doesn't increase their procedural risk. And so this is not a contraindication. Now for C, diverticulitis, this is a condition wherein there is like small pouches in the colon. There is that diverticula and they will become inflamed or infected. Now, if the diverticulitis is active, then aggressive bowel prep like PEG could increase the risk of perforation or worsening infection. However, the question does not specify active diverticulitis, so we cannot assume it's in an acute phase. And so in stable diverticulitis, PEG is safe, and that is why option A is the better choice. Now, what about letter D, colon cancer? This is a condition that often requires colonoscopy for diagnosis, staging, and also monitoring. And the polyethylene glycol is also safe unless the tumor is causing a complete bowel obstruction. And in this case, flushing the bowel could lead to severe complication. And since the option did not state an obstruction, there is no clear contraindication for option D. So I want you to make sure you investigate first the options and also the question stem. I want you to identify the keywords in the options, such as active inflammatory condition. This is supposed to trigger you to also consider the risk of perforation and worsening of the inflammation, especially when the client is using the PEG, or the polyethylene glycol. Now, I want you to also recognize stable versus active disease. And so if the condition is chronic but not flaring, such as polyps, stable diverticulosis, then the PEG is usually fine. Now, also consider about cancer versus polyps. These are common reasons for colonoscopy unless there is obstruction that is present. So PEG is not going to be a contraindication as well. 15. A nurse is educating a client who has just undergone an upper gastrointestinal series with a barium swallow. Which instruction should the nurse include regarding the post-procedural period? Options: A, expect stools to appear yellow for the next day after the test. B, barium might lead to loose stools for about 24 hours. C, drink extra fluids to help pass the barium in the stool. D, some minor rectal bleeding could occur as the barium is eliminated. The answer here is letter C. So, your patient here just had an upper GI series with a barium swallow, and you need to educate them on what to expect afterward. So the goal here is to make sure they clear the barium from their gastrointestinal system to prevent complications such as constipation or even impaction. And so drinking extra fluids is the most important post-barium swallow instruction, because the barium sulfate is a chalky substance that can thicken their stool. It can also increase the risk of slow fecal transit. It can lead to constipation and impaction. And again, I want to emphasize that your patient needs to receive adequate hydration to facilitate barium elimination by keeping their stool soft, and also to promote normal peristalsis. And take note that the barium is insoluble. It means that it does not dissolve in the body. It must be physically expelled. Now, if you selected letters A, B, and D, let's take a look into letter A here. Well, barium can affect the stool color, but it does not turn the stools yellow. Instead, it can lead to that light-colored white, or let's say pale gray stools due to its opaque, its chalky consistency. And so if you selected A, this is something that is typically due to maybe bile pigment alterations, or maybe rapid gastrointestinal transit, or maybe problems with fat absorption, let's say celiac disease, or maybe pancreatic insufficiency. And also we have letter B here. Barium might lead to loose stools for about 24 hours. This is also incorrect, and this is misleading, because barium sulfate is more likely to cause constipation, not diarrhea. It is a heavy, non-absorbable contrast agent that tends to slow the gastrointestinal motility. It's not going to accelerate the GI motility. And it has mild osmotic properties as well. It rarely draws water into the intestine to cause loose stools. And letter D here, some minor rectal bleeding could occur as the barium is eliminated. Well, the barium itself does not cause rectal bleeding because it is chemically inert and non-irritating to the intestinal lining. And so if a patient experiences rectal bleeding after a barium swallow, it is probably likely due to a pre-existing condition, maybe hemorrhoids or maybe anal fissures or a diverticulosis, rather than the barium itself. And the barium sulfate does not really cause direct trauma to the GI tract unless there is mechanical injury or maybe another underlying disorder. And so let's talk about the preparation here, especially with the upper GI series and barium swallow. And so take note that this is something that is indicated for patients that may have been complaining about upper abdominal pain, dyspepsia, or let's say dysphagia. If they complain about early satiety, or let's say if there is suspicion of obstruction. And so the test here, basically, it is a contrast enhanced x-ray that can allow the gastroenterologist to see the esophagus, the stomach, and the duodenum. And this is also going to detect any ulcers, any tumors, or maybe inflammation, hiatal hernia, or any obstructions in the GI tract. And the testing here involves a series of x-ray images using a contrast medium like barium sulfate. And the substance itself, the barium, is a chalky substance that makes the GI tract show up on the x-ray images. And so if there's any concerns about the GI tract, if there is already a suspicion that there is perforation, then gastrographin is used instead, which is a water-soluble contrast agent. And the test will typically start by having the client ingest that solution, and the radiologist will take images using the x-ray as soon as the barium or the substance or the liquid moves through the digestive tract. And they're going to look for those things like the tumor, inflammation or ulcers as well, or any structural issues. Now, take note that this is also a procedure that can contraindicate some conditions, such as complete bowel obstruction. There's also suspected upper GI perforation. And so the barium is going to be excluded here if there is GI perforation. However, if this is suspected, then the gastrographin is used instead. Now, another thing is the unstable vital signs. So this is something that will contraindicate the procedure. What else? We have patients that are uncooperative, especially if they were not going to be able to reposition themselves during the procedure, wherein they're supposed to change or shift positions while the radiologist is taking any images. And the procedure also has some complications. It's generally safe, but it can also lead to aspiration of the barium. It can lead to choking, especially if the client is not able to follow the instructions, and also can cause a bowel obstruction and constipation. Now, before you're going to send the client for this upper GI series with a barium swallow, make sure that you reassure the client that this is generally painless. Also explain that the test is generally harmless. They might feel some discomfort from the position changes or the barium drink, and make sure that they are placed NPO for at least 8 hours before the test, after midnight, right? And during the procedure, they're supposed to be drinking that 16 ounces of the flavored barium solution, which can feel a bit chalky. And the client here will be moving through different positions. They can be on their back, on their sides as well. And this will allow the barium to travel through the upper GI tract, and then the x-ray images are taken at specific intervals. Now, for x-ray detail, sometimes a carbonated powder is swallowed quickly to create air in the stomach to give a better view of the gastric lining. Now, after the procedure, you also need to monitor for the bowel movements. This is very important, right? And especially if the gastrographin is used, You have to make sure that the client is aware that they're supposed to expect some diarrhea. However, if they use the barium instead, they need to take a laxative or a milk of magnesia to help expel the barium, and this is to prevent stool impaction. And also remind the client that their stools should return to the normal color once the barium is all gone, which can take about a day and a half. So that is very important for you to reiterate all these teaching. Let's have number 16. A nurse is caring for a client who recently had an upper GI endoscopy. The patient's vital signs need to be monitored every 30 minutes for 2 hours post-procedure. After 1 hour, the unlicensed assistive personnel reports that the client, who was afebrile before, now has a temperature of 101.8 degrees Fahrenheit or 38.8 degrees Celsius. What should the nurse do next? Options. A. Ask the UAP to perform a tepid sponge bath on the patient. B. Plan to administer acetaminophen Tylenol to reduce the fever. C. Immediately check the patient for possible gastrointestinal perforation. D. Instruct the UAP to change the thermometer and retake the temperature. The answer is letter C. If there's a sudden temperature spike after an upper endoscopy, this is a concern for a possible perforation in the GI tract, and this can lead to the peritonitis and sepsis. And so you as a nurse here should perform a thorough assessment of the patient to check these complications. So make sure that you check them for any severe abdominal pain, abdominal rigidity, or any signs of shock before taking any further steps. Now, what about letter A? Ask the UAP to perform tepid sponge bath on the patient. Well, this is an intervention that is going to help lower the fever, but it should only be done once the cause of the fever is determined. And if the fever is due to the perforation, there is a need for an immediate medical treatment, and the patient should not be given anything by mouth. So this patient should be placed NPO until they are thoroughly evaluated by the medical provider. Now, what about letter B? Plan to administer acetaminophen to reduce the fever. Well, when you administer the Tylenol before you understand the cause of the fever is inappropriate. This fever could indicate a serious complication such as a perforation, and if you are giving that oral medication, this can actually worsen the client's complication. Now, what about letter D? Instruct the UAP to change the thermometer and retake the temperature. While it is possible that a thermometer malfunctioned, well, the immediate priority here is to assess the client for more serious conditions. And I've said that already. That could be a perforation. And so retaking the temperature can actually delay your assessment, and this could further worsen their condition. And so take note about the clues in the question here. There is a sudden onset of fever after an upper GI endoscopy. So this is raising the suspicion, the possibility of the perforation. So you need to be on top of your game here. 17. The nurse is providing a pre-procedure education to a client scheduled for an endoscopic retrograde cholangiopancreatography, ERCP. Which statements by the nurse are appropriate? Select all that apply. Options. A. You will need to avoid eating or drinking after midnight before the procedure. B. You may experience temporary difficulty breathing once the scope is inserted. C. A local anesthetic spray will be used to numb your throat and reduce gagging. D. The procedure is non-invasive and carries no risk of infection. E. During the procedure, you will be placed on your left side or supine. F. After the procedure, you may have a sore throat, which can be relieved with cool fluids or gargling. The answers are letters A, C, E, and F. Letter A, the patient should remain NPO after midnight to prevent aspiration during sedation, and endoscopic insertion. Letter C is also indicated. A lidocaine spray is applied to the pharynx to suppress the gag reflex, and this will make the insertion of the endoscope much more tolerable. And letter E, the client here will be typically positioned into supine or left lateral to allow the optimal endoscope navigation into the duodenum. And letter F, the insertion of the endoscope can also cause mild pharyngeal irritation, and so it is expected that they will experience that irritation, but it is something that can be relieved by gargles. Now, the option B here is incorrect. The scope does not obstruct the breathing. The airflow basically remains intact in this procedure, so this statement may cause unnecessary anxiety to your client. Now, letter D is also incorrect. The procedure is non-invasive. Well, that is already a false statement. It's not non-invasive. ERCP is invasive, and it introduces a risk of infection, particularly sepsis and cholangitis, because of the introduction of maybe bacteria into the bile ducts. So you got to investigate all those options. 18. A nurse is caring for a client who has just returned from an ERCP procedure. Which post-procedure interventions are appropriate? Select all that apply. Options: A, keep the client NPO until the gag reflex returns. B, encourage the client to drink warm fluids immediately to soothe a sore throat. C, monitor for respiratory depression and have a resuscitative equipment available. D, position the client in high Fowler's position to reduce aspiration risk. E, educate the client that mild hoarseness and sore throat are expected. F, immediately offer oral analgesics for throat discomfort. The answers are options A, C, and E. Why A? Well, this is going to prevent aspiration since the throat is anesthetized from the lidocaine. And letter C is also correct because sedation, for example, if they receive propofol, this will also cause respiratory depression, and we need airway protection and make sure that there is emergency equipment that should be available. Now, letter E is also correct. Throat discomfort is normal due to the insertion of the scope, and this is something that can be easily managed by gargling or cool liquids as soon as the patient's gag reflex has returned. And so we have letter B, which is incorrect. Encourage the client to drink warm fluids immediately to soothe a sore throat. Well, the word that makes this statement incorrect is immediately. You need to make sure that the gag reflex returns before introducing anything, any fluids, right? And this is to prevent aspiration. And also, we have letter D, position the client in high Fowler's position to reduce aspiration risk. Well, the patient should remain in lateral position until fully awake. So high Fowler's is not going to help at all. We have letter E, or letter F rather, immediately offer oral analgesics for throat discomfort. Again, oral analgesics immediately. This is contraindicated. You need to maintain that NPO status up until they have the gag reflex. All right. Again, gargles are also preferred for throat relief, not oral analgesics. Let's have number 19. The nurse is providing discharge instructions for a client after an ERCP procedure. Which patient symptoms require immediate medical attention? Select all that apply. Options: A, mild sore throat and hoarseness. B, severe abdominal pain that increases over time vomiting. D, fever and shaking chills. E, increased right upper quadrant tenderness. F, dark brown urine and pale stools. The correct answers are options B, C, D, E, and F. There's also E. So why letter B? The severe abdominal pain that increases over time is a progressive pain. This is possibly indicating pancreatitis, which is a complication of ERCP. and possibly it could have caused perforation. And these are both life-threatening complications. So you need to assess this as well. Now, what about letter C? Persistent nausea and vomiting. These are actually early signs of post-ERCP pancreatitis. So you gotta be mindful of this. What about letter D? Fever and shaking chills. These two suggest cholangitis or maybe sepsis, and these are serious complications that require immediate medical intervention. We also have letter E, increased right upper quadrant abdominal tenderness. So this is also reflecting worsening bile duct obstruction. Maybe there is gallbladder perforation or infection. And letter F, this is indicating biliary obstruction or liver dysfunction. There is that brown urine, darkening of the urine, and pale stool. So the bile is no longer able to flow into the duodenum. There is already blockage. So again, possibly there is migration of that foreign body that could have lodged into that area. And so this is going to cause blockage of the bile flow, and also it can cause blockage of the pancreatic juices as well. So again, this is something that you need to report to the medical provider. 20. The nurse is educating a client scheduled for a colonoscopy and another client scheduled for a sigmoidoscopy. Which statements about the differences in patient preparation for these procedures are accurate? Select all that apply. Options: A. Colonoscopy requires a full bowel preparation, while sigmoidoscopy usually requires only an enema or limited bowel prep. B. Both procedures require the client to be NPO after midnight to reduce aspiration risk. C. Sedation is typically used for colonoscopy, but is usually not required for sigmoidoscopy. D. A clear liquid diet is required for 24 to 48 hours before a colonoscopy, while sigmoidoscopy may only require dietary restrictions the night before. E. Air insufflation is used during both procedures, but sedation minimizes discomfort in sigmoidoscopy. And F. Colonoscopy examines the entire colon, while sigmoidoscopy only evaluates the rectum and sigmoid colon. The answers here are letters A, C, D, and F. Why A? Well, colonoscopy requires a complete bowel cleansing. Remember, we're supposed to administer or instruct the client to consume the polyethylene glycol solution and also possibly multiple laxatives, and this is to enhance proper cleansing of their bowel. And the sigmoidoscopy examines only the distal colon, and so preparation may involve an enema or mild laxative instead of a full bowel prep. Letter C is also correct. Colonoscopy is more invasive, and this will often require moderate sedation, maybe a propofol or midazolam. And the sigmoidoscopy is usually performed without sedation because it is shorter and less uncomfortable. And letter D, clear liquid diet is required for 24 hours to 48 hours. And again, the colonoscopy requires a longer dietary preparation period, such like I have said, in order to fully cleanse their bowel. And the sigmoidoscopy will require dietary restrictions the night before, and it does not always need a full liquid diet. We also have letter F, because colonoscopy visualizes the entire colon, the rectum, the ascending colon, and sigmoidoscopy can only examine the lower third of the colon, so including the rectum and the sigmoid, so making it a limited diagnostic tool. So B is incorrect. Colonoscopy patients must be NPO after midnight to prevent from aspiration. And sigmoidoscopy does not always need to be NPO unless sedation is planned, which is rare. Now, what about letter E? Well, both procedures use air insufflation to allow expansion of the bowel for better visualization. But with a sigmoidoscopy, this is typically done without sedation, so discomfort is not minimized with the sedation like in colonoscopy. 21. A 62-year-old male client with cirrhosis is scheduled for a liver biopsy to assess the extent of liver damage. Which of the following actions should the nurse take during pre-test preparation for this client? Select all that apply. Options: A, instruct the client to be NPO for at least 8 hours before the procedure. B, verify that the client has been informed about the risks of bleeding and the need for coagulation studies. C, ensure that the client takes anticoagulant medications as prescribed on the day of the procedure to prevent clot formation. D, administer a dose of vitamin K if there are signs of clotting abnormalities. E, ensure the client has a signed informed consent for the procedure. F, instruct the client to avoid taking aspirin or other blood thinners for at least 24 hours before the procedure. G, explain that the biopsy will be done under local anesthesia and sedation. The answers are letters A, B, E, and G. Why letter A? Well, for procedures involving sedation or let's say local anesthesia, being NPO is very critical to minimize the risk of aspiration. And an empty stomach ensures that the patient won't vomit during the procedure, which could lead to aspiration pneumonia or other complications. And typically, patients are asked to be NPO for at least 6 to 8 hours before the biopsy because of the possible complication of the liver it can cause liver bleeding, right? We also have letter B, which is correct because patients with liver cirrhosis are at a higher risk for bleeding because the liver is responsible for producing those clotting factors. And so it's critical to ensure the client understands this risk. And so we need to make sure that we have done the coagulation studies such as the PT, INR, and also the platelet count to assess the patient's bleeding risks. And we know that these are very critical in determining whether the patient can safely undergo the biopsy without excessive bleeding. Now, we also have letter E as one of the correct options. And so before any invasive procedure, we need to obtain the informed consent. It's required by law and also the ethical standards. So we need to verify that the patient understands the purpose, the risks, and the benefits of the liver biopsy, and the patient voluntarily agrees to the procedure. And this is a fundamental patient right and a legal requirement. Letter G is also correct. It is very critical to explain to the patient that the procedure will be done under local anesthesia to numb the area and also sedation to reduce the anxiety and discomfort. And this will help manage the patient's expectations and also to reduce any fear or anxiety before the procedure. Now, why are letters C, D, and F incorrect? So let's take a look into letter C. Ensure that the client takes anticoagulant medications as prescribed on the day of the procedure to prevent clot formation. Well, totally incorrect because anticoagulants are held before a liver biopsy to reduce the risk of bleeding. And the anticoagulants can actually cause or it can increase the risk of bleeding, especially in this invasive procedure. And so your role here is to check with the client the last time they ever took any antiplatelet medications or any anticoagulant. And if the patient has just recently stopped taking it, let's say 8 hours ago or 24 hours ago, it is your responsibility to notify the healthcare provider right away because this probably will require postponement of the procedure. Now, what about letter D? Administer a dose of vitamin K if there are signs of clotting abnormalities. Well, we know that vitamin K is typically administered to correct significant clotting abnormalities, but this should only be done if coagulation studies show that there is a true deficiency in the clotting factors. And Giving vitamin K routinely before a liver biopsy is inappropriate unless clotting abnormalities have been identified. So it is very critical for you to assess first the patient's lab results and administer vitamin K only if necessary. Now, what about letter F? Instruct the client to avoid taking aspirin or other blood thinners for at least 24 hours before the procedure. We know that our clients have to avoid aspirin and blood thinners before a liver biopsy, but take a look into the time frame. 24 hours before the procedure is not enough time for the medications like these drugs because they're supposed to be cleared from the system. So most often they're going to stop taking these drugs for about 5 days, at least several days. These medications are supposed to be withheld, and also depending on the type of medication they're taking. And this is intended to lower the risk of bleeding. And your responsibility here is to confirm with the healthcare provider for the appropriate timeline and compare it with the last time the patient has taken any of these drugs. All right, let's have number 22. The nurse is educating a client about stool occult blood testing. Which of the following statements by the client indicate a correct understanding of the test? Select all that apply. Options. A, I should avoid eating red meat for at least 3 days before the test. B, this test can detect even small amounts of blood loss in my stool. C, I should avoid vitamin C supplements before the test to prevent false negative results. D, if my test is negative, it means I definitely do not have colorectal cancer. E, I will need to collect multiple stool samples on separate days for more accurate results. F, if I take aspirin or anticoagulants, I may have a false positive result. The correct answers are letters A, B, C, E, and F. Letter A is correct because avoiding red meat before the test is very critical because it contains hemoglobin. And this can mimic the presence of blood in the stool and can lead to a false positive result. And what about letter B? This test is very sensitive, and this can pick up even small amounts of blood in the stools and amounts that wouldn't be visible to the naked eye. And that's why it's useful for detecting hidden bleeding from maybe colorectal cancers or ulcer. Now, what about letter C? Well, it's true because vitamin C can interfere with the test and can cause a false negative result. It simply means that it might hide the presence of blood. It's because vitamin C can block the chemical reaction that the test relies on to the detection of the blood in the stool. Letter E is also correct because collecting multiple stool samples on different days will give a more accurate picture. And the bleeding from conditions like colorectal cancer or ulcers can also be intermittent. So testing only once could miss this importance, right? Now, letter F is also correct because medications like aspirin, anticoagulants, and NSAIDs can irritate the stomach lining and it can lead to minor bleeding. While this doesn't necessarily mean there's a serious problem, but it can cause a false positive result on the testing. Now, letter D is the incorrect option here. It states, if my test is negative, it means I definitely do not have colorectal cancer. Well, a negative result does not guarantee that colorectal cancer or other conditions are not present, because some tumors or polyps may not bleed all the time. So they could go undetected if the test is done on a day when no bleeding happens. Let's have number 23. Actually, that would be the end of our session. And so, great job, everyone. You've made it through to today's review about the pre-procedure and post-procedure nursing care for the GI and genitourinary diagnostic tests. And I hope that this session has helped you strengthen your understanding of the critical nursing responsibilities before and after these procedures are done. And again, the primary reason is to ensure the patient safety and to make sure that we attain the accurate test results. And I want you to remember that the key to success on the NCLEX RN is not just memorizing steps, but also understanding the rationale behind the nursing intervention so you can confidently apply them in the examination. So I wish you all the best. I'll see you again.